Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Good morning, good afternoon, and good evening. This is Dr. Mitchel Muhleman, Associate Professor of Radiology and Division of Nuclear Medicine for the Department of Radiology at the University of Michigan. This video is on general nuclear medicine, CNS imaging, brain perfusion study for the evaluation of brain death. Disclosures, I have none. The objectives of this video: brain perfusion study for the brain death scan, indications, mechanisms of the radiotracers, technical procedure of the imaging, and case examples. Brain perfusion, brain death. Diagnosis of brain death is a clinical one, though may be difficult. Criteria necessary to diagnose: 1, the patient must be in a deep coma and total absence of brainstem reflexes or spontaneous respiration. 2, potential reversible causes such as drug intoxication, metabolic derangement, or hypothermia must be excluded. 3, the causes of brain dysfunction must be diagnosed: trauma versus stroke. 4, the clinical findings of brain death must be present and defined for a period of observation about 6 to 24 hours. With brain perfusion imaging, lack of blood flow is diagnostic of brain death. This is due to edema, softening, necrosis, and autolysis leads to increased intracranial pressure. Abnormal radionuclide angiogram is more specific than an isoelectric EEG. Radiotracers. Tc-99m DTPA was originally the first radiotracer used. This was used in a dynamic flow. It cleared rapidly from the blood pool, allows for repeat studies. Optimal technique was mandatory and is more difficult to interpret. An adequate bolus is required since there is no delayed static image is acquired. Newer radiotracers such as Tc-99m Ceratec, or Tc-99m ECD, Neuralite, are now favored to be used. These are neutral lipophilic agents with a high first-pass extraction across the blood-brain barrier. This corresponds to regional cerebral blood flow and relatively fixed in the neuron, allowing for delayed images. Flow studies are optional. Delayed images for fixed or absent uptake. Planar images are adequate. No spec CT is necessary. Interpretation: flow to both common carotids are seen in the base of the skull. Clear presence or absence of radiotracer uptake seen with HMPAO or ECD, easiest to interpret. Hot no sign, thought to be increased pressure to the external carotid circulation. Lateral views may show activity along the brainstem and the posterior fossa. This is non-specific and can be seen in patterns with internal carotid occlusion without brain death. Technique: patient preparation, there is none. Radiotracers used mostly as HMPAO or ECD, 20 millicuries. Instrumentation: gamma camera setup, large field of view, collimator, you want high resolution, low energy. The window is 50% over 140 keV photo peak. Camera formatter set up to 2 to 3 second flow images for 30 seconds, followed by immediate or delayed multi-view static images. Imaging procedure: inject radiotracer as an intravenous bolus. 2, acquire dynamic study. This is optional. 3, immediate or delayed 750,000 static images in the anterior, posterior, bilateral, lateral views. Static images of the injection site are also optional. Case 1, 47-year-old male, evaluation for brain death. Here we see the flow studies showing increased radiotracer activity, coursing up the common carotids, entering into the brain parenchyma. Delayed static images, so good radiotracer activity within the brain parenchyma. However, there is a defect in the posterior fossa of the brain. 1, these findings do not meet the criteria to confirm the clinical diagnosis of brain death. 2, complete absence of radiotracer accumulation within the posterior fossa is compatible with known posterior circulation infarct. Case 2, unknown head trauma. This is a textbook case. It comes from the Zeisman textbook. Image A, CT images of a head trauma victim shows a right frontal parenchymal hemorrhage extending into the ventricles. Image B is the flow images of Tc-99m HMPAO. Examination is the evaluation for brain death. The examination does not show early arterial phase of the perfusion, but good cortical perfusion and venous drainage into the superior sagittal sinus. Image C are anterior and right lateral images showing good delayed cortical uptake, although with a defect in the area of the hemorrhage. Case 2, unknown head trauma continued. Image D, a follow-up study 3 days later shows internal carotid arterial flow terminating at the skull base with no evidence of radiotracer activity within the brain parenchyma. Image E is anterior and right lateral static images. This confirms the absence of delayed cortical uptake. Any peripheral activity is due to external carotid flow. This is consistent with brain death. Case 3, 63-year-old female evaluation for aneurysm. CT images show large extra-axial hemorrhage in the posterior fossa with intraventricular extension and obstructive hydrocephalus. There is associated brainstem and cerebellar edema resulting in tonsillar herniation. Further evaluation with Tc-99m ECD. Dynamic perfusion images show radiotracer activity coursing through the bilateral carotid arteries entering into the cranial vault. Delayed static images of the anterior and lateral views show evidence of radiotracer activity within the cranium. There is no evidence to suggest brain death. Case 4, 25-year-old male, post self-inflicted GSW. CT images, multiple bullet fragments in the right frontal and parietal lobes with numerous associated punctate foci of parenchymal hemorrhage, significant cerebral edema and effacement of the basilar cisterns, traumatic injury of the right MCA and bilateral distal ACAs, subarachnoid hemorrhage in the right frontal and temporal lobes, and over the convexity of the left frontal lobe, communicated bilateral skull fractures as above. Case 4 continued with the evaluation of a Tc-99m ECD. Dynamic perfusion images show no evidence of radiotracer extending past the end of the common carotid arteries at the base of the skull into the cranial vault. Delayed static images show no evidence of radiotracer activity within the brain parenchyma. This is suggestive of brain death in the proper clinical setting. Conclusion: lack of blood flow is diagnostic of brain death. This is due to the edema, softening, necrosis, and autolysis that leads to increased intracranial pressure. You need an adequate bolus required for the Tc-99m DTPA. This is due to no static images. Flow to both common carotid arteries seen in the base of the skull. Clear presence or absence of radiotracer uptake seen with HMPAO ECD. This is easiest to interpret. Hot nose sign is thought to be increased pressure to the external carotid artery circulation. Lateral views may show activity along the brainstem and posterior fossa. This is nonspecific and can be a pattern seen with internal carotid occlusion without brain death. If uncertain, there is the absence of radiotracer activity within the brain from flow and static images, acquired SPECT-CT. References. Thank you very much.